There are a lot of developing countries in the world that have a decent infrastructure in terms of the healthcare, but they still need help. And there are many different avenues to help out. One of them is via medical missions. Consider a child with a cleft lip, for example. Studies have shown that that child will be traumatized psychologically while growing up, be more likely to have depression or mental problems or behavioral problems, be less likely to be married, to hold a job, to have children. So the burden on the child is quite enormous, and translated into the societal burden is great as well. This is Flavius. He's the son of a childhood friend of mine in Romania. He has an incomplete cleft lip and associated abnormalities, which will probably require several surgeries to reduce to acceptable scars. His is a mild deformity that is easily treatable and currently done in Romania. But consider those that are with much harder and more with a greater craniofacial or cleft malformations that require upwards to sometimes a dozen surgeries for multiple specialists from the time that they're born until they're into their adulthood years. What I'd like to tell you is our approach into how we dealt with this problem in a developing country, specifically Romania, that has a adequate healthcare infrastructure, but is not quite there to the next level. And there we go. As providers interested in international health, we perform international missions because we see that there is a need and we want to help. In underdeveloped countries, for example, organizations such as Doctors Without Borders actually sometimes replace the healthcare system because it is either lacking, such as currently in West Africa due to the Ebola virus, or failing due to conflict, as is currently happening in Syria. Nonetheless, in developing countries, though, such as those in Central Eastern Europe, after the fall of the Iron Curtain 25 years ago, the economies have grown significantly, and so has the infrastructure. While initially medical missions have filled in those gaps, as time went by, those gaps were reduced. So the question is, for an organization that has been in that country, investing time, investing resources, how can they adapt to remain active, because those countries still need help, but just not, they're beyond the medical missions. So that's the question that I've been dealing with, having done medical missions in Romania, and how to stay beyond the need for the short-term missions that we were doing. There are several types of humanitarian medical missions, including educational, clinic-based or medical, or surgical. They vary in duration from a few days to a couple of weeks to maybe semi-permanent, and such as in underdeveloped countries, run by organizations such as Doctors Without Borders, as mentioned earlier. Their impact can be minimal, where they just diagnose pathology but are unable to treat because there are lost to follow up, or the team is in the country for a short period of time, et cetera, to the maximum, or you're able to treat both acute and chronic pathology. In the missions that I've either participated or organized, I've kind of experienced throughout the spectrum. The worst type of mission that you can do is a so-called parachute mission, where you bring a team to a country for a limited time, you come in, and then after you're done, say for a week, you leave and never to be seen again. That's problematic because you are leaving the patients without any follow-up, and if they're undergoing surgery, for example, you are leaving them to fend off any further interventions to figure out on their own, or if they have any complications, to figure out where to go. And you will always have some sort of complications in a small percentage of patients. They can be something small where you just need daily dressing change, for example, or to something more extensive where you need hospitalization. So you're already placing a further strain onto that country's infrastructure. So the question begs, do medical missions if you're going to have a lack of follow-up, or if you're not able to continue providing for those patients? And part of it is, well, us as providers, we want to help, and we see the help that we can provide. And overall, medical missions, they do have a positive impact. But nonetheless, it is still a little bit egotistical on our part, too, as providers, because in a way, we see the medical missions as a vehicle for our own self-fulfillment, because we know that in the United States, if a patient is operated on, they will undergo a lot of follow-up, a lot of care post-operatively. So when you're judging medical performance in terms of surgery, you always look at patient outcomes, both in the short and long term, as well as consistency, safety, and cost effectiveness. So imagine how this is being done in the US, where this is closely looked at, and how it will be translated into a different country where you go for a week and then never to be seen again. Is that really fair to those patients in those countries, as well as to the healthcare in those countries? Or would it be better if you're able to teach the local physicians to do those surgeries and have them take care of the patients? So I'm a believer that the best way to approach this problem in a developing country that has an adequate healthcare infrastructure is by transfer of knowledge. So you build up on what you already have in the country, and you identify the gaps, and you work with the local health providers to fill in those gaps. So you're teaching them to fish, not providing the fish. And of course, you always can start with small fish. It doesn't have to be the big fish. So throughout the past couple of years in Romania, one thing that I've gone from was medical missions to being something that we're hoping to have a little bit more impact. Because as Romania has progressed economically and the health infrastructure has improved, we identified that the need for the medical missions was no longer as necessary as before. So with the help of a 3-year grant from Romania International and between a partnership between University of Virginia and University of Medicine and Pharmacy in Iași, we are able to make a sort of change in Romania. So to backtrack a little bit, when I was a general surgery finishing up at University of Hawaii, I saw that the need for change was happening, and I wanted to do something in my future specialty. And currently, as a plastic surgeon in training at University of Virginia, I'm able to use that know-how there, the technology sometimes, the experience, and implement it and making an impact in Romania by working with the Romanian specialists as well. It has to be a collaborative effort. So what we're hoping to achieve, and we've already started already, we've just returned from a 2-week trip a couple weeks ago, is to bring specialists from the US that are specialized and go to Romania and work with the Romanian specialists in seeing patients in clinic, discussing the cases, the indications for surgery, as well as when to do the surgery, the timing, the procedures to be done, performing the surgeries together, side by side, seeing the patients in the post-op period, in the immediate as well as in the long term, on follow-up visits, and we come back several times a year. Hold conferences specific related to the pathology that would be dealt by the center, And in doing so, we're trying to achieve a multidisciplinary approach on a very complex pathology, because we have the separate specialists in Romania, but they all work independently and haphazardly. So we are trying to build them together to form a team with the hope that this team will then be able to take care of the patients. And because there's a partnership between the two universities, we are able to keep the communication lines open via secure video conferencing and discussing cases where they may need be for help. So otherwise in Romania, the more difficult craniofacial or cleft cases would have to be operated on in the rest of the European Union at the cost of the national health system, which is obviously not cost effective, because a craniosynostosis, for example, can run sometimes up to $200,000, which if you were to treat it locally would be much less. So it is due to this type of program that Flavius and other children with different malformations will be able to lead a normal life. Thank you.
Thank you, Daniel.
Thank you.